Welcome to Moving Conversations, a podcast for movement professionals by movement professionals. If you coach, train, or teach movement, Pilates, or fitness, then this podcast is for you. With more than 60 years of experience in fitness and Pilates, your hosts, Brian Ritchie and Nora St. John, explore the science of human movement, diving deep into the facts, myths, and common misconceptions, hoping to spark thought and conversation about how we view fitness and movement. Now, let's jump into Moving Conversations. And welcome back to Moving Conversations. I'm Brian Ritchie. Joining me as always is Nora St. John. Morning, Nora. How you doing?
Very well, Brian. It's a beautiful day out here in California. I'm home for a few weeks, which is kind of novel and delightful. And I'm enjoying it. I'm enjoying just like getting back to a nice steady routine of working out and eating well and moving. It's been really nice. How about you?
About the same. Yeah, I'm going to be home for a little while. I actually looked at my whiteboard and I had a client ask me today, so when's the next time? I was like, I'm here for a little bit. This is nice. All right, I'm going to be home. And then it's like, oh, then I've got boom, 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 boom. And it's like, okay, yeah, I've got nine more events this summer and they all start at the end of July. So I'm like, okay, that's going to be a little bit busy for the second half of the year, but hey, that's what we do. And last year I was front heavy. This year I'm back heavy. So, and it'd be really nice if we could just spread it out and just do little chunks here and there. But sometimes you just got to do when people can fit us in.
That's the thing. That's the joy of our life. And if y'all think this is glamorous, because I've been talking to people who clearly think that being an influencer is glamour. We talked a little bit about this in one of our other podcasts. It's like, No, people, I'm sorry, man, but flying for 12 hours, ending up in a foreign country where you don't speak the language, ending up at some funky hotel. And I've had some odd hotels, I have to tell you, as I'm sure you have too, Brian, where, the host books you somewhere. One time I really realized, like not long after I walked in, that this was an old folks home, basically.
Oh yeah, you were telling me about that.
I walked to the lobby and there was all these, older people sitting in chairs, and there was like a little aquarium over there and some plants over there and a little table for things like, I don't know, mahjong or whatever they play over there. And it was not I don't know. It was odd. It was great. It was a nice little comfortable 1-bedroom sort of apartment thing, but it was not what I was expecting. We'll just say that.
I remember one place I got booked into, and I stayed with the owner of the company, and he had a room. I had a room, and we had a few other people working with us. It may as well have been called Bob's Motel. I mean, it was in San Diego. It was a mile and a half or something from the convention center, and obviously booked on one of these cheap website sort of things. It was so uncomfortable. The females revolted and refused to stay in the hotel. We had to put them up across the street from the airport. If any of you have ever been to the San Diego airport, the planes literally fly over this hotel. I'm sitting in the parking lot of the hotel. I look up, I'm hearing the vehicle I'm in starts shaking. I'm thinking, what is going on? Thinking, okay, California, earthquake was my first thought. And then I looked up and I swear I saw the belly of a plane that looked like I could have reached out and grabbed it. It was so close. And I looked across the street and there was the runway. And I thought, wow, okay, this is just the way it is. So yeah, glamorous it is not always. Occasionally we get put up in very nice places. Occasionally we have wonderful experiences on flights and can relax. And other times you're jumping between flights and you're sitting between two. I remember, oh my gosh, I was in Germany. It was one of these, you can book half of your flight. You can say where you want your seat, but then you get to your next thing and I'm on a Lufthansa and you don't get a choice. I am literally between two guys. And this was when I was a bigger man. I was probably 280 pounds at the time. And I'm sitting between two people and they'd call me small.
Oh God. Oh God. So your like shoulders are scrunched. They've taken over the armrest, right? Like they've totally taken over the armrest. You got no armrest to hang on.
Oh my God. I didn't need a seatbelt because I wasn't moving. I was not going to move during this flight.
Wedged. I'm wedged.
I was wedged in there and they're passing sausages between them to eat in front of my face. And part of me wanted to say, share. I mean, I'm sitting here, they're speaking German and I'm thinking, oh my gosh. Fortunately, it was an hour and a half, 2-hour flight. So I said, I can make it for that long, but oh my gosh. So yes, glamour, sometimes our travel is not.
Oh my God, that's a perfect image. I'm loving that image. All right,
Uh,
so
so
last
last
week,
week we talked with Beth about hip
mhm,
replacements,
right, and we
and it
got
was a
a fire hose download
oh my
of everything
gosh,
you ever need to know. It was like so a lot of
lots
information.
of information. Oh my
Yeah,
gosh, and I mean, afterwards, as soon as we sort of stopped the podcast, we started talking and saying, okay, we need a follow up because
yeah,
there was so much information that it's hard to parse that much in such a short period of time.
yeah.
But we also want to talk about things like case studies. I've had countless numbers of hip replacements and
Mhm,
literally from everything you can imagine. So I was thinking, okay, it'd be a good idea. I'm sure you had the same to be able to break that down and go over these things and also talk about the differences between the techniques and the positives, the negatives. There are. And these are things that, let's face it, with our clients, a lot of times if they're going to go into surgery, they look to us for guidance, for help, for opinions, because we see the rehab afterwards. We
mhm.
know the surgeries. And a lot of times they think, well, this doctor wants to do this brand new technique. And I'm like, how many have they done? 5. Okay. Well,
It's called practicing. He's
he's
practicing on
practicing at
you,
this point.
which at this point I would rather say they've done 200. I'm great. Okay, good. Then I'm going to be 201. I'm happy to do that. To be number 3 or 4 of a
No,
brand new procedure they're all excited about, they'll be paying extra attention, but
but they're
their
learning.
experience, yeah, they're learning. Their experience isn't where it is with a more familiar routine.
And you said the magic number. I had a surgeon client for a number of years, and he said, you know what? 200 is proficiency. He
Yeah.
said, after that is artistry.
Okay.
But at 200, that's when you are as proficient as you're going to be with the technique. You become a master after that. But that's sort of the minimum number, almost like we've all heard the 10,000 hour thing, whether or not that's true, I don't know. But he said 200 in medicine, according to him, was the magic number. Anything after that. So he always told me, ask how many they do. How many do you do a year? How many years have you been doing this? Because if you hear someone's been doing this for only 3 or 4 years and they do, one a week, few a month, maybe you want someone with a little bit more experience seeing under the scalpel. Maybe. That's just
It
my
I
thoughts.
it's such good information generally because so many of us don't know what to ask a surgeon. Oftentimes, if it is something like a hip replacement, typically, well, there's a lot of ways this goes, but you start with like your
Mhm.
GP or whatever your gatekeeper is on your insurance. They send
Yep.
you to some orthopedic person who may be a general practitioner who's specializing in orthopedics, not a surgeon, right? They kind of talk you through the whole process. Then you end up at the surgeon's office
Mhm.
oftentimes seeing the surgeon briefly and then seeing their PA or their physician's assistant for
Yep.
every other session. So those questions you don't always get an opportunity to ask those questions. And I don't know about you, but what is the best source of even finding a good surgeon? I ask my friends. I ask the doctor friends that I know,
Yeah.
right? Like, how do you find somebody who's good? And of course, then with surgery, you probably want them to be on your insurance plan too, because that helps a whole lot.
That
I'm not
helps.
spending $40,000 or $50,000 for a self-pay surgeon. But those things are always a little tricky. So I think that's a really good just rule of thumb. Like, how many of these have you done? Just out of curiosity. So like that'll give you a
And
sense.
yeah, and I don't know about you, but with my clients, all of them see the best doctors in the world, according to them. My guy's
Uh-huh.
the best. My guy's the best. I
Okay.
hear this, and maybe it's an area that I'm in, Washington D.C., high political influence. Everyone's trying to one up each other. Everybody has the best of the best of the best. And I see this doctor, I see this doctor, and they're the best. And you see
Mm.
these lists in magazines saying top docs and all of this, and I think, okay, well, not everyone can be the best.
No.
I want a really good mechanic. I don't need an F1 mechanic working on my truck, but I want a darn good mechanic working on it. I want someone working on my body who's done a ton of these, who's incredibly proficient, who's really good at answering my questions, and who's available to me and can answer those questions, and not necessarily someone who's the king of the world when it comes to this, because a lot of those bedside manner is not the greatest, and you may not get the questions answered that you really need.
Well, we talked a little bit about that with influence versus educators, right? It's kind of like, are they doing the
Mhm.
work, or are they talking about doing the work?
Yeah.
Because
Yeah.
I look at a lot of those best doctors of whatever, and generally they're things like plastic surgeons and things like that, which I understand, because those guys have to market, because they're generally not
100%.
covered by insurance, and it really is a product that they have to sell. But
Yep.
hip replacement, not so much. And
Yep.
and that is really where you kind of want the person who has a lot of experience with it and is really confident and competent with it. And there again, too, referrals. If you've got a lot of clients who've had that,
Yep.
ask them who's, how did this turn out? Or you have a client who
Mhm.
had a really good results. Who was your surgeon? Keep those names in your Rolodex. Oh my God.
Yes.
Just really seriously dated me. Okay. Not your Rolodex, in your phone. Keep the contact in your phone under medical professionals, because that's really, super helpful too, to have a list of people. Well, try this guy, try that guy. Maybe they're on your insurance, whatever the situation is.
No question. I think having that referral source is incredibly important. Incredibly important. And in today's technology, we talked about this with Beth. In today's new technologies, things are coming out all the time. I remember I had a client who was going in for a hip replacement. He was in his early 70s, maybe mid 70s,
Mm.
and he was going in for a hip replacement, and it was a new technique. And this was before the anterior approach became much more utilized. And it was more truly a lateral approach. It wasn't the posterior lateral, it was a lateral approach. And this guy actually invented the technique according to my client. And I thought, interesting. And he showed me a scar, and it was a very unique scar. It was almost like a 7. It was a right
Mm.
angle, and it was small, and it was truly lateral. And this guy had his version, and I've seen that there are other lateral approaches out there. And it was very interesting to sort of see that. But I've thought, okay, how many has the person done? How good was it? My client had wonderful results, but he wasn't an athlete. He wasn't someone who was going to go out there and try and run or play tennis or golf or anything like that. He just wanted to be, out of pain from arthritis. So with technology and a lot of people trying to, make themselves better, more proficient or whatever, techniques are going to be evolving. And we're in a state now where things are evolving, a lot more robotics. I'm hearing a lot about that, especially when I'm in Asia. I'm sure you
Yeah.
have.
Yep. The other thing too, there's the robotics. There's also something that Beth mentioned, which I thought was really interesting, was a much better ability to visualize the acetabulum and the
Mhm.
femur head and the geometry of that, and
Yes.
replicate that, through like 3D
Yes.
printing and other kinds of things. And that was fascinating, because I know, years ago it was kind of like, well, there's however many sizes, and you're somewhere between a 2 and a 3. But we don't have a 2.5, so we're going to
Yep.
make a choice to give you a 2 or the 3.
Yep.
Right. I mean, that was kind of where it was. And that sometimes meant that the results weren't fantastic, just because the hip didn't fit very well and didn't work as,
Absolutely.
quite like the other one, or the mechanics changed between the two sides. So that's really wonderful. I mean, those are some really good news that she brought, that things have improved to the point
Yeah.
where there's much more customization, which is awesome, because that will make a big difference in people's outcomes, I presume.
I would assume. I do know that 20 years ago, they said that 1/4 of an inch to 1/2 an inch of leg length discrepancy was fine and still functional. And that's still a successful surgery. And I thought, man, that's a large number. Anybody who's ever had a leg length discrepancy will know that 1/4 of an inch can be huge on the low back, on your spine, on everything that comes above and below it. And one of my clients had, after a hip replacement, I think it was a little more than 1/2 an inch, and had to have every one of their shoes had a new sole put on. You'd never know by watching them walk, but sure enough, they showed me their shoes, and I thought, oh yeah, they definitely had a different sole on one side to the other. And they said, yeah, it's a pain in the butt every time I buy new shoes. I got to go and have this custom on the outside, not the inside, on the outside sole of the shoe to make it higher. And I thought, wow, all because they were sort of those in between sizes. And she was
Right.
in the
Right. There
medical
were two and
field,
a
and she
half.
said, yeah, they brought in 3 from what the doctor said, and so they made the best determination based on what they saw. I thought, man, and when we think about hip geometry,
Mhm.
angle of the femoral neck, the twist, is it a little forward? Is it a little backwards? Is it turned there's so many variations that you can't just go in and say, well, this is going to be, everybody's is the same. No, they're really not.
No, not at all. Not at all. So and again, you've probably worked with more hip replacements than I have. I've worked with a few, but I think you've worked with more of them for more time, and certainly more recently, because I haven't worked with a
Yeah.
lot recently. But one of the things that I often say about hip replacements is, and this is based on all the people that I know that have had them, some of them were clients, some of whom are friends. It is when it is a successful surgery, it is a successful surgery.
Yeah.
I
Yep.
have so many friends who especially went in very good shape. These are generally Pilates teachers, serious athletes, movement
Mhm.
people, go in, have the surgery, do really good rehab on themselves, and come out able to do anything they want to do. One
Yep.
of them that I often think of is a massive skier. I mean, she does heli skiing and backcountry
Oh,
skiing
wow.
several days every winter. And this is what's possible.
Yep.
Right. So I think that's the good news in a way, is this is what's possible now with hip replacements.
Yep.
And the but is what I said in between there, which is she was in really good shape when she went in, and she
Mhm.
did really diligent rehab on the back end, and she
Yes.
knew what to do. And she went way beyond what the physical therapist said. She went way beyond, what the standard protocol is, and really
Mhm.
worked to regain as much function, stability, strength, mobility as she could after the surgery.
I think we're in an age now that the baby boomers are more of our clients. I'm a Gen
Hmm.
X, but baby boomers are more of our clients, and I think they have, unlike their parents, I think they have greater expectations of what they're gonna be doing for the rest of their lives. I
Yes,
think that,
statistically, that's true.
yeah,
Yeah,
they wanna heli ski, they wanna go skiing. It's like, I've worked
yeah.
for so many years. I'm retired now. I want to travel. I want to da 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 da. And they have those expectations. And to be limited by something like a hip replacement or a knee replacement or whatever is sort of like, no, I'm not going to be limited because I have things want to do and need to do. I've got my bucket list and I need to do them. So I think previous generations were much more, oh, I'm 65, I'm going to retire, I'm going to sit at home now, I'm going to sit in my rocking chair. And that's not what we're seeing. We're really seeing the people who want to push their bodies.
And also who are, and this is statistically true too, hip replacements are happening a lot younger
Yeah.
in people, right? That used to be like, you're 72, you fell, you broke a hip, we're going to replace your hip.
Yep.
Now it's, somebody who's 55, they've been a serious whatever they've been doing, and they need a hip replacement because they want to keep doing what they're doing, but they're 55.
Yep.
And any joint replacement that they talk about has a lifespan, and sometimes they can last kind of forever, but sometimes
Hmm.
they really don't last forever for a variety of reasons. And so the younger somebody is, the more you really want to make sure that hip replacement, that prosthesis, is protected as long as possible. So you
Yep.
really maintain good mechanics there so that doesn't wear out any sooner than it needs to.
And that's a great question you just brought up, is when do you do a hip replacement? Because the
Yeah.
traditional 20 years ago, I had this happen countless times where a client would suddenly come in with a cane. And I'd say, huh, okay. And they say, yep, the doctor said, use this cane. And when the pain gets too bad, then we'll do the replacement. And it usually was 2 to 3 months after they were given the cane, because if
Hmm.
they went in, the doctor said, yep, the arthritis is bad. Maybe you're ready for it, maybe you're not. And usually it was a mental component. Usually the person wasn't really ready for it yet. They wanted to be out of pain, but they weren't quite ready for a surgery because in their mind, this is so huge. And they were said, here's a cane. When the pain gets too bad and you're ready, we'll do the surgery. And so that was really a big question is, when do you do it? Now I'm having clients approach me saying, look, I'm 65 years old. I've just retired. My hip is killing me. I have so much I want to do. It's not, the doctor says I can probably put it off another 4 or 5 years, but then I'm going to be older and I'm not going to be as strong and this and that. Is it better to do it while I'm younger and I can recover faster? Or is it better to wait? And it's one of those questions that's like, I don't have the right answer for every single client because everybody's different.
My sister had a knee replacement about 1.5 years ago, and it was exactly that question in her mind. So she was, let's see, how old am I? She's probably 72 or 3 at the time. And the doctor said, well, yeah, your knee has been bone on bone for a while at that point. So clearly it was in a pathological state where a replacement would be a useful thing. And a pain state too. She was, on pretty regular anti-inflammatories. And she went that same calculus because she was pretty functional. Again, she's a Pilates mover. She's a gyrotonic person. She's been a dancer her whole life. So she knew how to manage the pain and how to manage that knee pretty effectively. But she was like, if I do it now, then I'm young, I'm energetic, relatively, I've got good ability to recover. If I wait 5 years, I'm going to be in my late 70s. Yeah. And that was really what, the same reasoning. She's like, I'm going to do it now because I think I will have a better result that will last me longer and not put me back as far. And that's pretty much turned out to be true. Like it worked well for her.
And I find that in general, there's a big difference between 70, let's say 71, 72 and 76, 77.
There really is. That's a big difference there.
There's a big difference.
There
it's
really
not
is.
like 42 to 47 where the body, you kind of got the same body you had. There's not much difference in tissue quality.
Even 55 to 60. I mean, honestly, like but when you get into the 70s, no, things really are a little different. Yeah,
it is. And I'm seeing this with my parents. I'm seeing it with a lot of clients. That when a client comes to me at 65 to 70, it's sort of, well, this is something you really need to consider is what kind of life and what kind of quality of life do you want for the next 4 or 5 years? If the doctor says you can probably put it off for 3, 4, 5 years, whatever, what kind of quality of life do you want?
Yep.
And if you want to have a very high quality where you can do everything you want and you want to go with your kids traveling and get up and down off the ground with your new grandkids and all of this kind of stuff, maybe earlier makes more sense. But if there's a huge fear or if there's someone who is prone to infection, if there's other reasons to put that off as long as possible, then those are considerations too. And we can't just jump into a single case of everybody should be doing it like this.
Right. Absolutely. So Brian, I want to bring up a couple things here. So one of the things is Beth talked in a particular way, and I wanted to bring that up because you and I mentioned it a little bit, but I think it's really important. She really talked as if everybody is getting excellent care, meaning that, meaning that they've got a really good surgeon and then they're given really good physical therapy afterwards from an experienced PT, and they're released from PT at the appropriate time once their strength, their mobility, their ability to do their daily life is at a certain level.
Right.
That's awesome. And that's wonderful when that happens. Yeah. You, like me, have had people where that was not the case, where they had a hip replacement and they had, 6 weeks of PT and then they were released and they were they're still limping. They still don't have like range of motion back. They're not as strong as they want. They can't really go up and down stairs very well. They can't sit for long. This is a problem. And this is sometimes who you might get in a Pilates studio is somebody who's really not at that, ideally not at the point where you should be working with them. They're a little early. If it's a client you've known for a long time and they trust you, they're going to come to you maybe earlier than you would like.
That happens constantly.
Yeah.
One of my mentors called it residual functional deficits.
Okay.
And that's really what it is.
What it is. Yeah.
Because they come out of physical therapy, they're given a certain amount of time. And I brought up the fact that Beth, sort of was like, that wasn't 100% sure, but I have had a number of people literally released from physical therapy days after they're released at home. They go home, they get home care for 3 visits. And what those 3 visits are, here's how to use a walker. Here's how to get it in and out of, off the john, in and out of bed, into the shower. It's more occupational therapy than physical therapy. How to put on shoes, basically how to use a grabber to help put on your shoes or a long shoehorn. It's that sort of thing. They weren't really getting the same amount of physical therapy that you would get in a normal PT's office, and they were released. And the doctor literally said, just start walking on it. Your body will figure it out. And okay, when I was 13 and I busted my arm, sure, I didn't need physical therapy afterwards because I played baseball, I did this, I did that, and I figured out how to use my left hand again.
Yeah, absolutely.
70?
You're 13.
That's a little bit more of a challenge.
The other thing we talked a little bit about, and we'll talk more about in our next episode, which is on a prehab kind of concept for knee replacement or hip replacement, is not only that, but if somebody has been in a painful situation with that hip for a period of time, chances are really good they've got some funky gait patterns happening anyway, because they've been avoiding hip pain for God knows how long, which often means that they're tight in their QL, they're tight here, their backs may be a little bit funky because they're just using their body in a very asymmetrical way often if it's a one-sided hip problem. And that means that all of that is still there after the replacement.
That's that's the whack-a-mole we've talked about, because
exactly.
My mother-in-law, she needed knee replacement for years. She put it off way too long. And guess what? She was walking up and down stairs using her low back. She was only hiking her hip. That's how she bent her knee to get up and down
all the way
stairs.
up. I mean, think about how high you have to hike your hip to not bend your knee. That's a big hip hike.
And after the surgery, her knees weren't the issue. Her back was on fire. And suddenly that was the issue. So you're going to see that. You're going to see that whack-a-mole, or as we sometimes say, it's like layers. One thing gets better, it's got that next thing, and it's got that next thing. And you create these compensation patterns as you go through life.
Yeah. Yep. Absolutely.
To avoid pain. We want to do everything to avoid pain and seek pleasure. That's the human experience.
Yep.
And if my knee's hurting, guess what? We're in Chicago walking around. Guess what? By the end of the day, I've got an arthritic big toe. It was hurting. My orthotics usually help for whatever reason. If I walk too much, it starts bothering. I was limping. I shortened my gait on my left foot. I realized I wasn't bending my toe as much. But I realized it because we study the body, and I could feel, wow, my gait is really funky. So I started taking shorter strides on both legs, trying to make sure I was walking a little more evenly. And I thought, but for the average person, that would just be a normal thing for weeks and weeks on end. And what would happen? They would create those bad compensation patterns. So that's what we're going to see with someone who is going through this much pain for a long period of time and needs that hip replacement, that they're not going to just be able to snap back and immediately walk on it and suddenly figure it out, because those other compensations are still there. You don't erase them just because you had the surgery.
So that in mind, like when I work with a client post hip replacement, I'm looking at a bunch of things in terms of just assessing things. And again, it could be a client like yours who's had really minimal care and is released into the wild probably earlier than they should be. Or somebody who even is maybe a year out, but still things aren't working well. They're still really tight here. Their gait's funky. They don't have endurance, whatever it is. And this is a basic hip assessment, right? We look at mobility. We look at strength. We look at range of motion. And then I spend a lot of time, as I'm sure you do, on functional movement, looking at gait, looking at how are they walking? How are they sitting down? How are they getting up? And I'm thinking of your environment and my environment are fantastic for this. I personally, I'm a little bit in a love affair with the core line right at this moment. And if I'm working on somebody with a hip replacement, And I can get them on a Coralon. I know, guys, this is a specialized piece of equipment that, Balanced Body makes that's really quite wonderful. But all the standing up patterning gait is incredibly valuable. Whole body integration, but really focusing on gait and reciprocal leg motion. Like that is getting them back to walking well, not walking, but walking well is a really key foundation of what I'm trying to get them to do.
Yeah. For me, a lot of it comes down to, I want to get them stronger. I want to get them more mobile.
Yep.
I want to make sure that they can do some of the basics in life, like get them up and down out of a chair. Because again, we're going to see those compensations where you're going to see them lean from one side to the next. And we've talked about this in our assessment thing. When they just walk in, watch how they move. How do they sit down? Do they use their arms? Are they pushing off with one side? Are they twisting? Are they doing all of these things? Because that's going to tell you a whole lot. And you can create your programming to sort of begin to work, or I'm going to use the word work around it. It's not the right term, but I want to begin to erase some of those compensations by saying, okay, I need to pattern them to use that left leg more.
Right.
So we're going to focus a little bit more on that. I'm not a huge fan of people of the whole concept of equal on each side. If they're weaker on their left side, do an extra set of one leg.
Exactly.
Why not?
I'm with you. Yep.
It's going to get stronger.
The dominant side will never give up being the dominant side unless you really work the other side. And actually, it often will never anyway. But the only way to get the weak side stronger is to work it, period.
Absolutely.
Again, working bilaterally doesn't get you there.
No. Yeah. One thing that I wanted to talk about and bring up, that Beth talked a lot about the anterior replacement being more of the standard. Now, in her practice, she works primarily, I believe you told me, with one group of physicians or one doctor. I've got a number who send their people to me, so I can tell you right now that I've got sort of my, cachet of people.
Every option, depending on the surgeon's preference. Yeah.
And that's the whole thing. There are 3 different approaches, and I think we should spend just a few minutes talking about each, because each has strengths and each has weaknesses. The anterior approach is sort of the newest approach, and about 20 years ago, the anterior approach was primarily there for revisions, when they'd have to go in again and remove the appliance that's there, and you do not want a revision. It is no fun. But that was typically, from what I've talked to a number of orthopedic surgeons, that was typically what they used for that, because it was just easier. They didn't have to worry about dislocating the socket and all these kinds of things, because it was just an easier way to do it. The posterior lateral was what the gold standard was. That's what almost everybody did. And again, if I had to do it today, I don't know which I'd want. Only saying that because with the direct approach, or excuse me, the direct anterior approach is what it's known as. It's the newest, it's the latest, greatest. As Beth said, it's supposed to, because they're moving muscles out of the way in order to create access to the joint. When you move the muscles out of the way, you're not cutting through them necessarily as much. And recovery is supposed to be quicker. And I just read a meta-analysis, and it says that the first 2 weeks, they seem to be recovering faster. But after 12 weeks, they're all equal, roughly.
That's interesting.
And that was
makes
what
perfect
I found.
Sense. I mean, if you're not trying to knit tissue together, which you have to with the posterior and posterior lateral approach, you're cutting through tissue, which has to actually heal. Back together, presumably, right? Has to kind of get organized. If you're only just moving things around, then yes, you're not having as quick recovery. At least recovery's quicker at the beginning because the tissues weren't damaged.
Exactly,
that makes perfect sense. But again,
makes perfect sense.
Yeah, at the 3-month mark, then the tissues are presumably knitted back together, and so then you're kind of at parity, right? Is that what they're saying? Interesting.
Yeah, is that they're pretty much equal. Now, with the posterior lateral approach, they're cutting through the glutes. Okay, they're primarily cutting through the gluteus maximus. It's more of it's coming from behind and to the side. It's a longer scar. I've seen as short as like 9 inches, as long as 12. I mean, I've seen some really large scars here. And it really is, you talk about invasive, they're really going through there. They're moving the sciatic nerve out of the way. They're pulling it aside, and they're cutting directly through, and they're going in. They have to oftentimes cut through all of the smaller external rotators, and then dislocate the socket and do all the work that they need to do. With a lateral approach, they're cutting through, depending on the surgeon. Sometimes they will just remove, they will cut at the insertion at the tendon, the gluteus medius, and move it out of the way. Sometimes they'll cut through the gluteus medius, depending on the surgeon, depending on their technique that they learned. So each of these, you're talking about additional time spent healing, because they have to cut into muscle tissue.
Right.
They have to. Now, the main difference that we find is with that, in the lateral approach, when they have to basically mess with the gluteus medius, a lot of times that can leave a limp. If you don't get good care afterwards, it can really mean that side never quite catches up. That gluteus medius is always sort of a little weaker. Again, great physical therapy can help with that. What we do can help with that. But we do see, I could not find, I looked everywhere. I could not find any data that said a third of them are here and, 40% do this approach. Every doctor's a little different, so we don't have those numbers. I don't see a lot of lateral approaches. I think the posterior lateral is still kind of the big one that we're going to see versus the lateral. But when they are cutting through those muscles, that's going to take some time to heal.
Well, and what happens when you cut through something? You end up with scar tissue. And scar tissue creates stability. That's its whole point, right? Is to glue together pieces that are not attached anymore. But scar tissue also, depending how somebody builds scar tissue can create stiffness, can create weakness, can decrease the glide in the fascial layers, and things can kind of stick to each other. Sometimes you'll have scarring that kind of goes through multiple layers, and all of that can change those mechanics. One thing too is if there is scar tissue, whether it's from actually cutting through the tissues like a posterior lateral approach, or whether it's even just moving the tissues out of the way and probably disturbing them somewhat in that process with an anterior approach, the way that, from fascial science, the way that tissues heal the best is by being first being used in the way that they need to be used, kind of being released from the tension and getting rid of the gluey bits. So manual work or that kind of thing to get rid of the sticky bits that are not allowing it to move as it should, and then training it to move and to create fiber angles and fascial fiber angles in the direction of pull where you really want it to be. And that's movement, right? That's not being immobilized. That's not sitting on your chair. That's movement. And repetitive, regular, consistent movement is what makes those changes.
And getting them to move as quickly as possible does seem to help. Now, I'm going to say this. Sure. The difference between them, the first two, we talked about this with Beth, the posterior lateral approach. We really want to avoid certain ranges of motion, and for how long. I hear different things based on different doctors. One doctor will say forever, another doctor will say 3 weeks. You hear different things. So, but the traditional for the posterior lateral, you don't want to flex them above 90. You don't want to do internal rotation or come across the body past the midline. Those are the ones you want to avoid, because if you think about it, that's how they dislocated the hip to remove it from the socket in order to do the replacement when they went in.
And the way that I remember that, Brian, is don't sit and cross your legs.
Yeah.
For a client, it's like, because they're like abduction, adduction, flexion. Like, just imagine you're lifting your leg up, you're going into more than 90 degrees of hip flexion, you're going into probably some internal rotation, and then you're going into some adduction, right? That's exactly where you pop that femur the most out of the socket, right? That's kind of,
and we're talking about crossing your legs where you're here and not sort of just putting the ankle on the other knee, because that's external rotation. Depending on the person,
it's crossing it like ladies cross it.
Bingo.
Like ladies in a skirt cross it, if that helps.
Exactly. That's the
Yeah.
best. That's a great way to put it. Because again, that is what will sort of distract that out of the joint, possibly. Again,
Yeah.
I've never had someone have that happen, but I have heard horror stories from physical therapists that have had, patients that have had that happen. But that's sort of one of those question marks of when are you allowed to do that? When can you work those? You just have to be monitoring that, especially in the Pilates setting, because we do a lot of adduction. And could that create some instability because that is fairly strong and gets stronger, and there's not as much abduction? Maybe. But this is just something we have to work on balancing, because we want both to be strong. We really want them both to be strong.
So thinking about exercises like kneeling abdominals facing back, right, which is a traditional exercise, at least in the balanced body repertoire. Right there, you're going into hip flexion above 90 degrees. That's the whole point of it, is to get the psoas a little bit stronger. And that's where you'd want to be careful of that, right? You want, especially at the beginning. Now I know I can think of one of my instructors or educator that I know, teacher that I know, who had 2 hip replacements, and she specifically asked for hardware that allowed her to maintain an unusual amount of hip mobility.
Huh.
So she was a dancer, and she wanted to basically be able to still lift her leg up above 90 degrees in and so the doctor chose a prosthesis and an acetabulum that basically allowed more range of motion.
Wow.
Yeah.
That's interesting.
So that was novel to me. And she had, again, she said both hips replaced and had that's been very successful. Other things she's had issues with, but the hip replacements have been extremely successful. And she really had amazing range of motion afterwards, which was a little scary to all of us who worked with hip replacements. But it's like, okay, you do you. If that works for you and you know how to manage that, go for it. I would never, ever, ever do that with a client, but I'm glad you can do it.
Wow. Yeah, because if you think about it, there are certain exercises in Pilates, feet and straps that you've seen this before. People who are incredibly flexible, they're going to want to show off a little bit and go into larger ranges of motion. And people, we all know these people who want to do certain exercises no matter what their bodies are telling them, because I just love the way it feels. Okay, but your new hip may not. So you just have to sometimes be aware and remind yourself, okay, in this position, that hip is going a little bit above 90. Maybe we restrict that range of motion for now until we get thumbs up from the physician. The thing I want to make mention between these 3 that I find the most fascinating and one of the most irritating for the clients is what happens if there's nerve issues. Because, and I say this because I've had a number of people that have had issues with a direct anterior approach that have nerve issues. There's something called the lateral frontal cutaneous nerve. And that nerve sometimes gets cut. Sometimes it gets tractioned out of the way during the surgery. And then they end up with this numbness. And they say it's anywhere from 12 to 80% of people. Now, that's a gigantic number. This was the meta-analysis, so I'm just throwing the number out there. From what I've talked to physical therapists, they say, they see it about 20% of people. Sometimes the numbness goes away. I've had some people that it drives them batty. They say it's like a little small Nerf-sized football about this big, not where the scar is, sort of anterior to the scar, that's numb all the time. And anybody who's had sciatic pain and numbness down the leg, it can be incredibly irritating. And some people it comes back, and some people it never does. And that numbness and throbbing and whatnot just sort of is persistent forever.
Well, that would make sense. Nerves don't like to be messed with. And I always say, nerves have a memory. Remember, they go up to your brain and they have a memory. And once they get insulted, sometimes they remember that insult for way longer than you'd hope they would.
Yeah.
Huh.
And nerve
That's
issues with the posterior approach is about 1 to 2% because there is a sciatic nerve. And sometimes when they're getting it out of the way, they traction it a little too hard. They do a little bit too much compression, and that can cause some issues. More often than not, that does come back. The sensation comes back, but they say anywhere from like 1 to 2% of people with that approach, sometimes that does occur. But again, that's a 1 to 2%
that's pretty
versus
small, right?
that's very
It,
small.
it kind of speaks to the robustness, honestly, of the sciatic nerve versus this much smaller, cutaneous nerve in the front. Because, the
Yeah.
sciatic nerve is pretty honking and you can kind of take the whole thing and just move it. And I suspect that the other nerve is a lot smaller and can get nicked without even realizing you're in it. If you've ever seen like those little tiny nerves that run through tissue, you have to look for it to make sure you're not doing something to it. Interesting.
And let's think about this too. If you're doing the anterior approach, you're still cutting some tissue. You can't sort of go in there without going in there. So even though they say we're moving things out of the way, there's still fascial tissue you need to cut. There's still skin, there's adipose tissue, and there is nerves running through that. There are blood vessels.
Absolutely.
There's still all of that needs to be gotten through. Now, the interesting thing is that if you have a much higher BMI, they are much more reluctant to do an anterior approach. And I think just because those tissues are sort of in the way, they say people with big meaty thighs or people who have a much higher BMI, they're much more reluctant to do that. And could that be a reason why? They have to cut through a whole lot more and it's a little more difficult? I don't know. But they say that that's one of those big question marks that they'd rather do the posterior lateral approach. So again, these are all things that, I'd heard. I was reading this meta-analysis and it was really kind of fascinating sort of seeing the actual numbers. But the main number was the outcomes at the 3-month mark, 6-month mark, 12-month mark were almost identical between all three approaches.
Brian, it'd be good to, again, I'm not sure how many nerds are really out there, but to put the reference for that in the show notes.
I will.
Because I think that sounds really interesting. That sounds like a really valuable thing just to have in your back pocket and to be able to refer to. And again, I would say, at least in my experience, that the outcome, apparently, at least I'm not sure the meta-analysis says this, but the outcomes I think are as much based on how much. So given that they're all are equal in the in those time frames, that the results are really a lot dependent on what the person does.
100%.
Right. So I've got to assume that then it's not so much the surgery that's going to influence that outcome as it is how you, as a person with a hip replacement, or you as a person teaching a person with a hip replacement, work that client back into as full a functional ability as you can, good mobility in the hips, good strength, particularly in abduction, good range of motion in terms of, I imagine, and you can talk to this, I imagine hip extension gets a little limited with an anterior approach. To end up a little tighter on the, that's what I would assume is, and we know that causes troubles all the way down the pike, when, especially honestly in the Pilates studio where hip extension is kind of a thing. And if you're lacking hip extension, especially on one side, you're going to be pretty asymmetrical in terms of how you're moving, and a lot of common exercises like bridging or knee stretch or other kinds of things.
Now, what I've noticed, this is anecdotally, but also from the literature that I've read, is that for the anterior approach, those limitations, it's sort of the opposite limitations of the posterior lateral. So you want to avoid hip extension and external rotation, but for a very brief amount of time. They usually say until the tissues really heal is when you want to avoid that. So you're talking weeks, you're not talking years.
Yeah.
And from what I've seen, they get that range of motion back a lot faster because they're not doing as much damage. There's not as much scar tissue within the musculature because more of it was able to be moved out of the way, that they do have sort of that range of motion comes back to them a little bit quicker. And again, this is anecdotal. I've had a number of people who have had this, but that's sort of, I've had more that have had the posterior lateral. And for them, there's a lot more restriction. And I will say, functionality wise, I see it faster in the anterior approach. But over, like I say, the course of 6 months to a year, becomes about the same. But you're right. It's what you do with the person. It's what we're doing, the exercises that we choose, what they do on a regular basis, and what they can do consistently. Because if they're not willing to work consistently, it's not going to work for them. And they're going to have limitations. And those limitations, I said this with Beth, you get one shot to do great physical therapy and to do great rehab. After that, you're really playing catch up, and it can take you 2, 3, 4 times as long to get back that same functionality as if you took it right from the start and did great rehab at the beginning and took it seriously.
And this gets back to just, I was saying earlier about when tissues are healing, when things are getting used to where they are, right? Everything's in a slightly different position than it was before. If you let that settle in, if you let that scar tissue develop, if you let those stiffnesses develop, like repairing that can take forever.
Yep.
Whereas if you really start the movement and patterning the movement ASAP, and again, there's all kinds of limitations. The first 6 weeks, you're pretty careful of a lot of things, six weeks to 3 months. You're a little still careful. And then after that, you're a little bit less careful. But basically, like really getting the movement patterns, even if it's non-weight bearing or very relaxed, very simple. I think of like leg slides, right? Or even assisted leg slides or supported leg slides, just things that are getting that mobility going in the appropriate way, getting those tissues to respond. That's where you're going to rebuild the tissues in the appropriate way, as opposed to, again, letting scar tissue and stiffness develop that then you have to get rid of later.
And this is what I love about the springs, because when you do use the springs on the Cadillac, I can give so much more assistance with range of motion. So I can get them to do a lot of ranges of motion that they're really not strong enough necessarily to do on their own at the beginning. Whereas I can de-weight them. And I mean, you said it great in the last episode, by moving the bars in different places, you can change where that vector is coming off of the spring. So you can, and by changing that, it can give them assistance, whether they need more flexion or abduction or adduction, whatever it is, you can really adjust it and fine tune it in a way that before I used the Cadillac, I mean, I was doing it with bands with, trying to tie them up behind the person and trying to do it in some weird ways. The Cadillac is so good for that. It is wonderful.
Yeah. All the feed and strap stuff, that's my go-to post-hip replacement. And really with any hip issue, sort of, if I'm doing prehabilitation, I start there too, or anybody with a hip problem. It's like just getting the motion going with support. You can start, I would say, kind of like below zero, right? Because you're taking gravity off. So if I'm, let's say, lifting my leg to the front in basic hip flexion, that might be too hard for somebody or cause a lot of pain. I add a spring to that, I de-weight that leg, and then suddenly they can do the movement and get that pattern back in their body, start to get the strength going, and then we just build that up. Whether it's abduction, adduction, extension, or flexion, like all those things we have the abilities to do on the table as supported as we need to. And that's been like my absolute go-to.
And what's great about it too is you're actually strengthening the opposite side. So if I'm assisting with hip flexion, as they put that leg back down, guess what? They're actually getting their glute and hamstring focused on as well. If you're doing it in abduction, you're getting the adductors firing as you pull that leg down. So it's only beneficial. I have not had a person that I put on there that has not gotten benefit from it, because by de-weighting it, it assists in so many different ways, and I can really adjust on how much of their body weight they're using. And even if it's a heavy spring, they're still getting a lot of, of that other side. So their glute is getting involved.
Strength and support, right? So they're getting strength in one direction and mobility in the other direction. And again, at whatever level they can tolerate.
Yes.
And that's been my classic go-to for people that are pre-hip replacements, where I'm just trying to get the muscles firing around the hip again, because a lot of times they've gone wacky or gotten a little dysfunctional because of pain, and just getting them going again, like waking them up in a way that they can do it without increasing the pain. And those things that's just a wonderful tool for that.
Absolutely. 100%. And something to keep in mind when you're working with these people. And again, I often will see them probably before they should be coming back in. I hate to say it, but they've been released from PT, or they've only gotten 8 visits or whatever it is. Everybody has different medical insurance and different limitations. And some people just, I'd hated my physical therapist, so I want to come to you. We get that too. And when you're getting those people, work within where they are today.
Mm-hmm.
And I say that because there's a lot of times when we get bored before the client does, and we want to push them. In physical therapy, a lot of times they push them a lot harder sometimes than maybe they're ready for. Not always, but occasionally I see that. And then they come to me and say, oh my gosh, I'm in so much pain because of that. So I say, find what level they're at, work with that, get them comfortable, make small adjustments, increase the resistance slowly, and they're going to get stronger. I take my time with it. I don't try and rush them through. Physical therapists often only have a certain number of sessions to get them to a certain level, so they have to move faster. I don't have to.
Oh, I was going to say we have the luxury in a way of really letting it be as progressive as it needs to be.
Yeah.
And the other thing too is I've become much more of a fan of this. And I know many of you have trouble with getting your clients to do homework, but in something like this, homework is critical.
Crucial.
Absolutely critical that they do something. And it can be very simple things. What I usually say is give them 3 things. Don't give them 20. They will not do any of them.
Nope.
If you give them 3, they may do those 3. So these are the 3 most important things you need to do. And it may just be like standing at their counter doing heel raises, right?
Mm-hmm.
Like that. It may be standing on one leg working on balance. It may be walking around the block. Like just give them 3 things that they can do that really help to focus on getting the mechanics back, moving the leg in appropriate directions, like whatever the thing is.
And make them accountable for it.
Yeah.
Call them on it. Consistency. I remember I was teaching a class up in Canada, and I was talking with one of the other instructors who was running the fitness facility. And he said, look, how many times a week do people come and see you? I said, between 1 and 3. I think that's the average. But again, we charge a lot. So for some people, it's once a week. He said, how can someone be consistent with once a week?
Yeah, agreed.
They can't.
Right.
And that struck home for me a lot more than I ever thought it would. And I remember on the flight coming back, I thought, wow, that really sort of underlines the importance of homework, underlines the importance of making sure they're consistent when they're not in front of us, and then following up and asking them the questions. Hey, did you do your homework this week? Oh, I did it once. Well,
okay, great.
Okay.
Then let's try for twice next week. Right?
Let's work on 2. I
Yeah.
tell them every day, and it's a psychological thing. If I tell them every day, I'll be lucky to get it 3 times. But if I tell them 3 times, I'm lucky to get once.
Exactly. No, so just tell them every day. There's one of the teachers that I work with said something that I really like, and it's a little phrase I'm going to keep in my mind, which is that consistency is the currency of the body.
Ooh, nice.
Yeah, and it's like so true, right? Whatever you do regularly is what your body learns to do, period. And you know that. If you got a client once a week who's doing nothing else, their progress is pretty flatline. Like they might make a little progress, but it's pretty flatline. Twice a week, you get some. 3 times a week, like, man, you could be like a rocket ship. So, really consistency is what really makes the change. We just know that. That's how the tissues work. That's how the brain works.
Yep. 100%. I couldn't agree more. Keep them honest about it. Make sure they're doing their work, and keep changing the homework too, because I find even I become a little bit complacent sometimes because I give them the exercises and they're doing it great. And then I have to remind myself after a month of it, well, it's time to change those.
Right. I got to upgrade. I got to upgrade. That.
Exactly.
Yeah.
So that's something I have to even remind myself. So we all sort of get into those patterns. So keep them honest, keep them working, and get them moving as soon as they can comfortably. And that word comfortably is sort of whatever way they can. Exactly.
Yeah.
There may not be comfortable, but you got to get them
right.
moving.
And that's the thing, is comfortable enough. And that can be a fine line, right? Comfortable enough, not causing irritation, not causing inflammation, not causing a vast increase in pain, but they may not be comfortable. I mean, like a lot of my clients are chronic pain clients, and everything they do hurts. It's just a matter of it hurts in the direction of getting better rather than it just hurts and it's in the direction of getting worse. And that's that's always a tricky one.
I think we covered this pretty well. I think there's a lot of information here.
There is.
You know, I think
Yeah.
after the last session or the last one with Beth, it was sort of, okay, this can't be covered in a single hour because there's
Right.
so much. And like you said, we are all in our own little bubbles. We all have our physicians who send people to us or the people that we see on a regular basis. We're not a hospital that sees hundreds of thousands of people a year. We have a small subsect of doctors that send people to us. And so our experiences are going to be limited based on, I'm in Washington, D.C. If I was in Omaha, Nebraska, I'd
Mhm.
probably be seeing different people.
Mhm.
You know, if
Yep.
I was in Calgary, I'd be seeing different people. So we always have to remind ourselves of that as well. Uh, so that's just something to keep in mind.
And I know to really appreciate, Bren, that I think a lot of what we've talked about here is in some ways not the ideal circumstance, right?
Yeah,
Like the
exactly.
things that may show up, nerve issues and different things that happen with different surgeries and different things that we've seen happen with clients, getting clients way early in their rehab process. Like those are also just kind of the reality that we sometimes face.
Hmm.
So I really appreciated that. I also really appreciated that meta-analysis study, which is like, oh, well, that's all good information out there. So thank you for bringing that forward too, to really bring some
Sure,
grounding
sure.
into
And we'll
this
put it in the show
conversation.
notes so that you can read it. I'll be honest, I read through it and I need to read it probably 4 or 5 more times before I get 100% of it because it's very, very dense. And it's based on
Yeah.
not a ton of studies. They're only like 24, 25, but let's keep in mind
Mm.
the anterior approach for hip replacements is still kind of new. 15 years ago,
Mhm.
it wasn't done that much. I remember my
Yep.
first clients going into it and they're saying, oh yeah, my doctor's only done 4 of them. I'm like, I don't know about
Mm.
that. Now
Right.
they've got a lot more experience. So there's more studies that are being released on a regular basis. So there are some meta-analysis out there. So you can look those up. I will put them in the ones that I saw in the show notes so that everybody has those.
Great.
Now, I will say this, do us a favor, hit that like and subscribe button. I know I forgot to mention that earlier, but we really appreciate it. Every time you do, it helps us out a ton, especially when you comment. Uh, the majority of the people that listen to our podcast are not subscribers. So if that's you, do us a favor, hit that subscription. Some episodes may not float your boat. It may be sort of like, I don't know if I really want to. You don't have to listen to it, but it helps us out. The more subscribers we have, the better it is for us. And we get this in front of more people so we can really help some people. So we really appreciate every one of you for listening. If you want to reach out to us, do us a favor. We can do it through email, through movingcombos@gmail.com, or through our Instagram page, Moving Combos. Those are the best ways to get in touch with us. You can also check us out on YouTube under my name, Brian Ritchie. So for Nora St. John, I'm Brian Ritchie. We'll see you next week.
Bye, guys.